Welcome back to the deep dive. You've handed us the essential blueprint for understanding how we, as orthopedic professionals, quantify success, or perhaps, just as crucially, quantify failure after an injury or surgery.
Right.
This isn't just about, reading the x-rays. It's about translating a feeling into a number.
That's exactly right. Our objective today isn't just to look at the post-op hardware alignment or the latest manual stability tests.
Right.
We are conducting a rigorous systematic review of the mechanics of patient-reported outcomes, or PROs. And, just as important, the sophisticated statistical framework we need not just to record those numbers, but to actually trust them.
I think of it as bridging the clinical chasm. Objective measures. A stress x-ray showing ligament laxity, a goniometer reading, the sheer mechanics of the joint. Those are our foundations.
Sure, they're the bedrock.
They tell us if the hardware is fixed correctly, if the alignment is acceptable. But if we stop there, we're basically fixing a vintage car engine without ever asking the driver if it feels smooth on the highway.
That's a great analogy.
We have to bridge that gap between our objective assessments and the patient's actual, lived experience and their perception of function.
And our deep dive today pulls insight directly from the comprehensive work analyzing dozens of specialized sports knee rating systems. I think it's 43 different instruments, in fact.
43.
And the foundational biostatistics required to rigorously interpret them, all guided by key reviews in the orthopedic literature. The mission is, at the end of the day, fundamentally clinical.
How so?
We need to select the appropriate, most sensitive instrument for a specific population and pathology, and then, and this is the critical part, understand what the resulting numeric score actually means for that patient.
We're going to be swimming in alphabet soup today, so let's nail down the primary ingredient first. When we talk about patient-reported outcomes, PROs, what are we defining, technically, for the person who might be using or interpreting these scales?
Okay, so PROs are essentially a standardized series of survey-style questionnaires. They are now an absolutely foundational fixture in orthopedic literature because they're the mechanism that lets us track a whole collection of outcomes.
Everything from
localized pain and stiffness to global quality of life, and all from the perspective of the individual who matters most, the patient.
Okay.
And they have to be designed not just to ask good questions, but to quantify those subjective values on a scale that is demonstrably reliable, demonstrably valid, and can be compared across entire patient populations.
Reliability and validity are the non-negotiable anchors here. If I give a patient a survey today and then I give it to them again tomorrow when nothing has changed, and I get wildly different scores,
the scale is useless.
Exactly. It has low retest reliability.
Precisely. To successfully integrate any PRO instrument into a busy clinic or a high-stakes research trial, the scale has to do two things extremely well. First, it must accurately represent the patient's underlying condition. That's validity. The truth. And second, it must be sensitive enough, that's responsiveness, to detect the often subtle changes that result from our treatment. We need to know if that small improvement we think we saw in the PT notes is something the scale can actually register above its own noise floor.
Okay, let's zoom out. Before we get into the really specific knee ligament function scales, we often start with the global assessment.
Yeah.
If we're running a total knee arthroplasty registry, we don't just want to know if the patient's knee bending improved.
Right.
We want to know if the surgery changed their life outside the OR. Did they go back to work? Are they sleeping better?
And that's the critical role of the general health scales. They're essential because they measure overall health status or quality of life, QOL, rather than focusing narrowly on just one joint.
Which means we can make these huge comparisons.
Exactly. Because they aren't disease-specific, they allow for massive, wide-ranging comparisons. Not just comparing different ortho procedures, but comparing, say, a knee replacement patient against a cardiac bypass patient.
Which, for orthopedics, means we have to discuss the classic general health audit. The SF-36 and its practical little brother, the SF-12.
The short form 36 item form, or SF-36, is the historical and highly respected general health questionnaire. It involves 36 questions covering broad aspects of overall health.
And the SF-12 is just the shorter version.
It is. It's a highly utilized 12-item version, sharing 12 items with the full SF-36. These scales are internationally validated, available in multiple languages, and are cornerstones in research on everything from chronic back pain to knee and hip OA.
So 36 questions is a bit of a commitment for a patient in a busy clinic. What are those questions actually grouping together? What are the domains?
They're carefully grouped into 8 distinct subscales designed to paint a holistic picture. You have physical function, roll physical, which is how much physical health limits your daily rolls, bodily pain, general health perception, vitality.
Energy and fatigue.
Right. And then social functioning, roll emotional, how much emotional problems limit daily rolls, and finally, mental health.
You can boil those down.
Yeah, you can score the individual subscales, or you can calculate a physical component summary score and a mental component summary score.
And that distinction between the physical and the mental component is so key. You might have a perfectly aligned knee replacement, but if their pain perception is refractory and their roll emotional score is tanking,
You haven't succeeded.
not by the patient's definition, no.
Exactly. And the scoring is straightforward. It's scaled from 0, representing the worst imaginable health state in that domain, to 100, representing the most healthy state.
Okay, so why would a researcher or a registry choose the 36-item version when the 12-item is so much faster? Is that marginal gain in information worth the extra 3 minutes the patient spends filling it out?
It absolutely can be. While the SF-12 is the workhorse for huge studies where speed is paramount, the SF-36 provides superior granularity and reliability in certain populations.
Also,
Crucially, the SF-36 has demonstrated better specificity and is significantly less likely to suffer from what we call floor and ceiling effects.
wait, let's define those effects for a moment. What does it mean if an instrument has a ceiling effect?
A ceiling effect happens when a big chunk of your patients achieve the maximum possible score.
Okay.
And that means the instrument can no longer register any further improvement. So if you're tracking recovery in an elite athlete after an ACL repair and your function scale maxes out at can run a mile, they'll hit that ceiling really quickly.
And you can't track their return to professional sport because the scale just runs out of room.
Precisely. The SF-36, being more detailed, offers a higher ceiling and thus better sensitivity for tracking recovery in these high-functioning groups. It's almost always used in combination with a region-specific scale to get both the global and the detailed knee assessment.
That makes perfect sense. Now, let's move to the most ubiquitous scale we use every single day in the clinic.
Yeah.
The one that measures the unquantifiable. The visual analog scale, the VAS. This is that simple 100-millimeter line.
The VAS is arguably the gold standard for measuring subjective pain intensity. It's used everywhere. The basic concept is a 100-millimeter horizontal line with these carefully chosen polar descriptors.
No pain at one end.
And worst imaginable pain at the other.
And the technical measurement is just the distance.
Correct. The distance in millimeters, measured precisely from the 0 point, represents the patient's subjective pen level at that specific moment. Now, we often use the alternative, the 0 to 10 numerical scale, in a fast-paced clinic because it's quicker for the patient and easier to document.
But there's a cost to that simplicity, right?
There is. While the 0 to 10 numerical scale is patient-friendly, that simplification can limit the scale's sensitivity. The 100-millimeter line is continuous. It allows for subtle differences of 53 versus a 54.
Right.
The 0 to 10 scale forces you to categorize, which might limit its ability to detect subtle but clinically meaningful change over time in a longitudinal study.
So when we talk about that longitudinal data, we need to know the magic number, the point where the change actually matters to the patient. What defines success on a VAS for any patient?
We have pretty concrete data for this. A clinically meaningful change for knee osteoarthritis patients is established at 19.9 millimeters. Let's just round that up to 20 millimeters.
Right.
And for patients presenting with anterior knee pain, the threshold is also right around 20.0 millimeters.
20 millimeters. Let's make that real for a second. Suppose I have a chronic knee OA patient whose VAS pain is 75 millimeter. I give them an injection, and a month later they report 65 millimeters. That's a 10-millimeter improvement.
Right.
Statistically, it might show a trend, but based on that established clinical threshold, that 10-millimeter change is likely meaningless to their daily function. They don't feel dramatically better.
And that's the critical application of this metric. If you fail to cross that 20-millimeter tipping point, you have not offered a change that is subjectively large enough to justify the treatment. You might have statistical significance, but you lack clinical relevance.
We have to respect that patient-defined threshold.
We do. And it's fascinating that the VAS concept is so powerful. It's used as the underlying framework for more complex multi-item scales, like the knee disorder subjective history, which grades 28 items on a 10-point scale based on this VAS principle.
Finally, in this section, we have the simplest assessment of all, the Global Rating of Change, or GROC. This is often the patient's instantaneous gut check on how they feel things have gone.
The GROC scale is the most basic PRO. It just assesses the patient's subjective appraisal of their overall change after treatment. A common version is a single 15-point scale.
And how does that scoring system break down?
It typically ranges from a maximum positive value, say +7, which means a great deal better, through 0, meaning no perceived change, all the way down to a maximum negative value, say maybe 7 for a great deal worse.
So its strength is its simplicity.
Absolutely. It provides an immediate global understanding of the patient's perception of the outcome. However, it is fundamentally subjective. The literature has shown that this global perception of change may not accurately correlate with objective or even detailed functional change measured by other scales over time.
It's the ultimate subjective measure. The patient might feel a great deal better, a +5, simply because they were told the surgery was successful. Even if their objective function hasn't changed at all, we have to use it cautiously.
Very cautiously.
So we've moved from the general physical, the SF-36, to the broad pain assessment, the VAS. Now we need the highly specific tools, the MRI sequences, if you will, that zero in on joint function, ligament stability, and specific symptoms. We need the right PRO for this specific pathology.
Right.
Let's start with one that every sports orthopedic surgeon lives by, the IKDC subjective form.
The International Knee Documentation Committee Subjective Knee Evaluation Form, or IKDC, is really the quintessential standardized assessment tool for knee injury outcomes. It was first published back in 1993 and revised in 1997, and it's designed to measure subjective outcomes across a whole spectrum of knee pathologies, not just ligament injury.
Tell us about its structure. It feels concise but very comprehensive.
It contains 18 total items, which are meticulously divided into 3 sections. 7 items address symptoms, things like pain, swelling. Locking 2 items address general function, like requiring support. And then 9 items specifically assess function during sports and daily living.
And the scoring.
The raw scores are converted to a 100-point scale, where 100 represents the best possible function and a complete absence of symptoms. And a practical note here, it remains scoreable even if a patient completes only 16 of the 18 items, which ensures high utility in big clinical trials.
Where does its strength truly lie, in terms of population?
Its validity and reliability are really robust across a broad range of orthopedic conditions. ACL reconstruction, meniscal injury, articular cartilage procedures, and patellofemoral pain. Its depth in capturing specific functional limitations, stair climbing, running, jumping, makes it invaluable for tracking active populations.
So if a new ACL technique improves the IKDC score, what magnitude of change are we looking for to call it a success? What's the number?
The suggested minimally important difference, the MCID, has been cited at 11.5 points for the IKDC. But, and this is a big but, the literature reports a really wide span of values depending on the specific study population. Sometimes it's as low as 3 points, sometimes over 16.
That variability is a huge challenge when you're trying to compare studies.
It is. And what about the instrument's own error, the MDC?
Right, the minimal detectable change.
The MDC reported for the IPDC is also widely variable, cited as ranging from 6.7 to over 20.5 points. So if a study reports an improvement of 5 points and the scale's inherent error is 6.7 points or more,
then you can't confidently state that a true change even occurred.
Exactly. Regardless of the MCID, we must see a change that exceeds the MDC before we even start considering the MCID.
Okay, let's shift gears to the patient demographic dominated by degenerative conditions. For osteoarthritis, the WOMAC is king.
The Western Ontario and McMaster University's Osteoarthritis Index, the WOMAC, is the primary tool for assessing symptoms and function in lower extremity OA. It is the absolute workhorse in tracking older adult populations.
And its structure.
It consists of 24 items broken down into 3 subscales: pain, which has 5 items, stiffness with 2 items, and function with 17 items.
And the scoring is a Likert scale.
Yes. Patients use a Likert scale to rate each item, choosing from categories like none, mild, moderate, severe, or extreme. And, like the IKDC, the scores are normalized to a 100-point scale, but the interpretation is inverted.
Inverted how?
A score of 100 represents no symptoms, perfect health, and 0 represents the worst possible symptoms. It's the most widely reported subjective outcome measure for lower extremity OA, period.
What's the magic number for an OA patient undergoing a treatment, say, a joint preservation procedure or an arthroplasty?
Clinically, an MCID is firmly established at 9.1 points in the total WMX score for patients with knee OA. This index is highly valued because it is not only valid and reliable, but also exquisitely sensitive to change over the chronic time frame that's required to manage OA.
Now, if the WMAC is a foundation for OA, the Knee Injury and Osteoarthritis Outcome Score, or KOS, is the logical evolution, the modern multi-tool.
That's a perfect description. The KOS, published in '98, was designed specifically for patients with knee OA, but was constructed to include the foundational pain, stiffness, and function sections of the WMAC.
So they built it on top of the WMAC.
They did, and that structural overlap is intentional. It allows researchers to easily benchmark KOS results against historical WMAC data, which is a major advantage for research continuity.
But its real power comes from its broader applicability.
Precisely. It's used far beyond just primary OA. It's applied to virtually any knee injury, ACL reconstruction, partial meniscectomy, ligament repairs. That carries a risk of leading to post-traumatic OA down the line.
It's a massive scale, though.
It is. It's comprised of 42 items divided into 5 separate subscales: pain, symptoms, function in daily living, or ADL, knee-related quality of life, QOL, and function in sport recreation.
With 5 subscales, there's always the temptation to just average them into a single, neat number. But we are strongly advised against that, correct?
That's a crucial technical point, and yes, combining them into a single composite score is strongly discouraged.
Why is that?
The reason is the variable item counts across the subscales. For example, the ADL subscale has 17 items, while symptoms only has 7. So combining them arbitrarily distorts the overall representation, weighting ADL much more heavily than the patient's symptoms. Researchers must analyze and report the subscale separately.
For the young, active patient, the competitive runner or skier, which parts of the KOSs are the most responsive? Where does it really shine?
The KOS absolutely shines in younger, active populations. It's been shown to be most sensitive to therapeutic change, specifically on the function in sport recreation and the knee-related quality of life subscales.
That makes sense.
Those are the areas where the smallest change has the biggest impact on the patient's satisfaction. But we have to acknowledge the sheer variability in the MDC values reported for its subscales. They can range from a relatively low 9.9 points for symptoms up to a staggering 70.0 points for sport recreation.
70 points.
70. It reflects the difficulty in reliably measuring high-level athletic function across different settings.
So that means if I want to confidently say my intervention improved an athlete's KOS sport recreation score, the improvement has to be massive just to overcome the measurement noise. That's a huge barrier to showing efficacy in the elite population.
It is, and it reinforces why we have to look at the subscales individually and contextually.
Let's quickly review the 3 other essential scales that complete our clinical picture. First, the Lysol knee scale.
The LISOM scale is widely used for assessing knee ligament injury and surgical outcomes, particularly historically. It's comprised of 8 weighted items: assessing limp, the need for support, stair climbing, squatting, instability, locking, catching, pain, and swelling.
And the numbers.
It scores up to 100 points, and a minimum clinical improvement, or MCID, of 10.1 points has been established. Because it lacks a deep dive into high-level activities, it is almost always combined with an activity scale like the Tegner.
Okay, and for patellofemoral pain, the Kujala scale provides the necessary focus.
The Kujala Anterior Knee Pain Scale, or AKPS, is a 13-item scale specifically tailored to patellofemoral pathology, also scored up to 100. It focuses intensely on daily symptoms related to common activities that stress the PF joint: walking, running, squatting, and critically sitting for long periods.
But it has limitations.
It does. While it's valid for tracking treatment effect in anterior knee pain, its utility is limited when you're trying to differentiate the underlying mechanical cause, say, differentiating between a patient who had a single patellar dislocation versus one with repetitive instability. It measures the pain, not the mechanics of the event.
And finally, the Tegner Activity Rating. This is the simple scale that provides context for all the others.
The Tegner, developed way back in 1985, is a straightforward 0 to 10 scale describing the patient's typical daily activity level. 0 means disability due to the knee injury, and 10 represents participation in elite international competitive sports.
And it's crucial for establishing a baseline.
Absolutely crucial. It establishes what the patient was doing before the injury, allowing us to track return to sport or loss of function post-injury.
For an ACL patient, what defines a successful return to activity on the Tegner?
The MCID is very small, but very specific. It's 1.0. A patient must change at least 1 full level on that scale for the outcome to be considered clinically important.
And this brings us back to the significant caveat we have to discuss. The Tegner is a victim of time, especially in long-term follow-up studies.
It is a massive confounder. If we use the scale for young patients who are 9s and 10s in competitive sports, a score transition from a 9 down to a 7, 5, or 10 years later might have nothing to do with our ACL repair technique.
Right.
It may simply reflect the patient graduating from college sports, pursuing a career, getting married, or having children. Their lifestyle naturally necessitates a lower activity score. The surgical success might be perfect, but the Tegner declines anyway.
That's the challenge for research integrity. We have to acknowledge that when we look at 10-year follow-up data on a cohort of former collegiate athletes, that means Tegner score drop is likely a consequence of aging and lifestyle shift. And we can't statistically separate that without using something like an ANCOVA to control for age.
It forces us to ask, are we measuring surgical outcome or are we measuring the inevitable march of life?
Yeah.
And a final scale worth noting for this population is the ACL quality of life measure, the ACL-QOL. This is a 32-item scale tailored specifically for patients with chronic ACL deficiency.
And it has some predictive value.
It does. Interestingly, studies have shown that patients reporting significantly lower scores on this scale were statistically more likely to pursue reconstruction surgery, suggesting it provides some predictive value regarding surgical intervention preference based on their perceived functional burden.
We've established what the measures we use. Now we have to audit ourselves and cover the how well. If our metrics are wobbly, if our scale has excessive inherent error, or if our interpretation is flawed, then the conclusions we draw from these massive, expensive trials are useless.
Right.
We need rigor. We need the statistical toolbox to establish truth and reproducibility.
We have to start by defining the absolute foundations of measurement integrity. We need clarity on 4 concepts: reliability, validity, accuracy, and precision. These terms get conflated all the time in general conversation, but they have distinct, non-overlapping statistical definitions.
Let's start with the classic pairing: reliability versus validity.
Okay, so reliability is all about consistency. It addresses the reproducibility of a measure. Can we get the same measurement repeatedly when the underlying condition hasn't changed?
Yeah.
If I measure a patient's extension deficit multiple times today and the results are clustered tightly together, that measurement is reliable. Validity, on the other hand, is about truth.
Is it measuring what it's supposed to measure?
That's it. Does the IKDC truly reflect knee function, or is it heavily confounded by something else, like pain tolerance? If it reflects function, it's valid.
So a test can be reliable, but not valid. For example, a bathroom scale that consistently reads 10 pounds too high is reliable. It gives the same result every time, but it's not valid because it doesn't represent the truth.
A perfect analogy. Now for the other two. Accuracy and precision. Accuracy describes the ability of a test to differentiate between positive and negative diagnoses. It's calculated by taking the total number of correct diagnoses, true positives plus true negatives, and dividing that by the total number of patients tested.
And precision.
Precision describes the repeatability of a test result with multiple testing. Are we yielding similar scores when the same patient is tested on multiple occasions? So you can see precision is very closely linked to reliability.
This sets the stage for sensitivity and specificity, the cornerstone of our diagnostic tests. This is how we move from a physical exam finding to a diagnosis.
And to define these, we have to use the standard 2x2 contingency table framework, comparing the results of our diagnostic test against an established gold standard, like an arthroscopy or an MRI.
Okay.
So sensitivity is the ability of our test to detect true positives. It's the proportion of all patients who actually have the disease who tested positive on our exam.
Like the Lachman test for an ACL tear.
Exactly. And if a highly sensitive test is negative, it helps rule out the injury. That's the mnemonic, SNNOUT. If the Lachman is highly sensitive and the patient has a negative test, we are much more confident in ruling out a tear.
And specificity is the inverse.
Correct. Specificity is the ability of the test to detect true negatives. It is the proportion of all patients who do not have the disease who tested negative. If a test is highly specific and the patient tests positive, it helps rule in the injury. The mnemonic is SPPP-on.
So a highly specific test, like the pivot shift, if it's positive, helps rule in the ACL injury with high confidence because it rarely gives you a positive result in a normal knee.
That's exactly right.
And that makes the clinical application so clear. If I'm doing a mass screening for something rare but serious, I want a highly sensitive test so I don't miss any cases. But if I'm confirming a diagnosis before an irreversible procedure like a fusion, I need a highly specific test to avoid operating on a patient who doesn't need it.
And we build on sensitivity and specificity to derive the true measure of a test's utility. Likelihood ratios, or LRs. These ratios move beyond just the percentages and describe the actual shift in the probability of disease caused by a test result.
This is where we start getting into Bayesian thinking. How does a positive likelihood ratio work?
The positive likelihood ratio, the plus LR, is calculated as sensitivity divided by 1 minus specificity. This ratio tells us how much the odds of having the disease increase if the test result is positive.
So, for example,
For instance, if an MRI finding has a plus LR of 5, a positive MRI indicates that the patient is 5 times more likely to have the specific outcome of interest, say, a meniscal tear, than they were before you even did the test.
and the negative LR.
The negative likelihood ratio, or LR, is 1 minus sensitivity divided by specificity. This describes the impact of a negative clinical test on the probability that the disease is still present. So if a negative Lachman test has a LR of 0.2, a negative result means the odds of the disease being present are now only 2 out of 10 times what the pretest odds were.
These ratios are crucial because they let us move from abstract statistics to actual patient management. If a test has an LR of 1, it's useless. It doesn't change the probability of disease at all.
Right. We're always looking for LRs significantly greater than 1 for positive results and significantly less than 1 for negative results.
And graphically, we visualize the performance of these diagnostic tests using receiver operating characteristic curves, or ROC curves.
Right, the ROC curve.
Tell us how to read one.
The ROC curve is a highly visual graphical representation of that trade-off between sensitivity and specificity. We plot sensitivity on the vertical axis against 1 minus specificity on the horizontal axis. The key metric we get from this curve is the area under the curve, or AUC.
Okay.
The AUC is a single estimate of the overall diagnostic value of the test. A perfect diagnostic test, one that can always distinguish between those with and without the condition, has an AUC of 1.0. If the curve runs diagonally from the bottom left to the top right, the AUC is 0.5.
Which means the test is no better than flipping a coin.
No better than random guessing, exactly. So when you're reviewing literature on a new diagnostic test, you're looking for an AUC that is as close to 1.0 as possible, typically above 0.8, to justify its clinical use.
Okay. This section is the moment where rigorous research confronts the reality of patient care. A finding can be statistically significant, that famous p-value of less than 0.05, but be utterly meaningless to the patient receiving the treatment.
Right.
We need thresholds that dictate if the change is worth the patient's PT co-pays, their time off work, or the risk of surgery.
And we have to internalize this distinction. Statistical significance is about probability. Clinical importance is about magnitude and meaning.
Let's start with the ultimate definition of success from the patient's perspective, the minimal clinically important difference, or MCID.
The MCID is defined as the absolute minimum difference in an outcome score that the patient perceives as beneficial. Critically, it's the threshold that would necessitate or justify a change in treatment.
It answers the question, is this big enough to matter?
It directly addresses the question of whether a statistically significant finding is large enough to translate into a tangible, felt benefit for the person who underwent the intervention. It prevents us from celebrating a 1 millimeter improvement on a pain scale that the patient genuinely does not notice.
So how do researchers even calculate that subjective threshold?
Yeah.
It sounds incredibly difficult to quantify perception.
It is challenging, and no single method is universally accepted, which is why MCID values can vary so widely across studies. But there are 3 primary approaches.
Okay.
The first is the distribution approach. This involves comparing the calculated confidence intervals, or CIs, between 2 treatment groups. If the range of the CI from one group does not overlap with the range of the CI from the second group, the difference is statistically and clinically inferred to have reached clinical importance.
This is a very mathematical way of defining the gap.
It is. The second, and perhaps most common, is the anchor approach. This is the practical validation method. It requires comparing the changes detected by the new instrument against an established, validated gold standard, or anchor, often the patient's GROC score or their VAS pain score.
So the researcher might ask, what score on the IKDC, the new instrument, correlates best with the patient answering +3 or better on the GROC, the anchor.
Exactly. They find the IKDC score threshold that maximizes both sensitivity and specificity against that anchor, and that becomes the MCID for the IKDC in that specific study population.
And the third?
The third is the expert opinion approach, which relies purely on input and consensus from patients themselves or experienced healthcare professionals to define what constitutes a tangible, meaningful change. This is often the least mathematically robust, but provides crucial qualitative context.
Okay, now let's pivot to the statistic that tells us about the instrument itself, independent of the patient's perception. The minimal detectable change, or MDC.
The MDC is the smallest change in score that can be confidently detected by the measurement tool itself, over and above the noise created by inherent measurement error.
So it has nothing to do with the patient.
Nothing. This statistic is purely a comparison of the clinical finding to the inherent error present when that specific tool, whether it's a scale, an instrument, or a physical exam maneuver, is used repeatedly.
We need to spend a minute on the MDC because it's often overlooked in favor of the flashier MCID.
Yeah.
Give us the goniometer analogy and expand on its clinical significance.
Okay, let's assume we're tracking knee extension range of motion. If we establish that the specific plastic goniometer and the specific technique used in our clinic have an inherent MDC of 8.2 degrees, this means that if we measure a patient's knee extension twice and they haven't actually improved, the difference in the readings due to natural error could be up to 8.2 degrees.
So that's the noise.
That's the noise. Now, a patient comes back after a week of intense physical therapy. Our resident measures their change in extension and notes a 4-degree improvement. That is below the 8.2 degree MDC.
So we can't be sure it really happened.
We have very low confidence that a true physiological change actually occurred in that patient's knee. That 4-degree difference is likely just measurement error.
That is a fundamental barrier. The scale literally couldn't reliably detect that small a change. And this has enormous practical implications.
Absolutely. Think about reimbursement and treatment continuation. If insurance requires an objective, measurable functional improvement to continue physical therapy, and the scale you're using has an MDC of 8 degrees, but the patient's objective change is only 5 degrees.
Insurance might cut off the therapy.
They may, even if the patient subjectively feels better. The MDC sets the bar for detecting change, while the MCID sets the bar for meaningful change.
So for the highest confidence in a research finding, we need a finding that is statistically significant, exceeds the MDC, meaning it's real and reliably measured, and exceeds the MCID, meaning the patient feels it. All three must align.
That alignment is the definition of high-quality evidence in orthopedics.
And finally, effect sizes. If the p-value is about probability, and MCID, MDC are about clinical utility, the effect size is about magnitude relative to the variability of the population.
Effect sizes are crucial because they standardize the measure of a treatment effect across different studies. They're calculated by taking the mean difference between the treatment groups and dividing it by the standard deviation of the population.
And how do we interpret them?
The standard interpretation is straightforward. An effect size below 0.2 is considered small. Between 0.2 and 0.5 is medium, and 0.8 or higher is considered large. This lets us compare the strength of interventions that might have used different PRO scales or different patient populations.
Now we zoom out to the population level. Epidemiology is how we track success, or often the failure rate of our interventions over time. It's how we identify trends and complications or predict long-term outcomes like post-traumatic OA. It makes us medical detectives.
Epidemiology is the study of the distribution and determinants of injury and disease in human populations. For orthopedics, we rely heavily on measures of frequency and measures of association.
Let's clearly define the measures of frequency. Prevalence and incidence. They're so easy to confuse.
Prevalence is static. It's the proportion of individuals who have the outcome right now at a single point in time. It's calculated as the number of existing cases divided by the total population at risk.
A snapshot.
A snapshot. Incidence is dynamic. It's the proportion of new cases of an outcome that occur within a specific established time interval. Calculating incidence fundamentally requires a follow-up period.
A video, not a snapshot.
Exactly. And a derivative of incidence is absolute risk. If we track 100 patients undergoing a patellofemoral reconstruction, and 6 of them report severe anterior knee pain that requires a second surgery within 6 months, the absolute risk for that complication is 6%.
Okay, moving to the measures of association relative risk and odds ratio, these are how we compare the likelihood of an outcome between two groups.
Relative risk, or RR, compares the incidence of injury or disease between two cohorts. an exposed group, like patients who underwent an ACL repair, and an unexposed group, like age-matched controls. RR is calculated as the incidence in the exposed group divided by the incidence in the unexposed group.
And because it requires incidence rates, RR is primarily used in which study designs?
It is most appropriate for prospective cohort studies or randomized clinical trials where we start with healthy groups and follow them forward to see who develops the outcome. Interpretation is relative to 1.0. An R of 1.0 means the risk is identical. An R of 2.5 means the exposed patients have a 2.5 times increased risk of developing the outcome.
And the odds ratio.
The odds ratio, or OR on the other hand, compares the odds of an outcome. OR is calculated as the odds of the outcome in the exposed group divided by the odds in the unexposed group. ORs are far more common in retrospective or case control studies, where we start with the outcomes, say, patients who developed OA, and look backward to see what the exposure was.
And we have to emphasize a crucial statistical caveat here regarding the OR.
Yes. While the interpretation is similar to RR relative to 1.0, it is a major error to interpret an OR directly as an RR when the outcome is very common.
Why is that?
If the outcome is rare, the OR approximates the RR pretty well. But in orthopedics, where we often study common outcomes like chronic pain or post-traumatic OA, the OR can vastly overestimate the true risk compared to the RR. Researchers have to be very careful about confusing odds with risk.
Let's shift to the final, highly technical part of the framework, hypothesis testing. This is how we prove or disprove our theories about one procedure being better than another.
The choice of statistical test is dictated entirely by two things: the type of data we have and how that data is distributed. First, data types. Continuous data has an infinite number of possible values: age, height, weight, most PRO scores.
Okay.
Categorical or discrete data is limited. It can be binary, yes, no, ordered, mild, moderate, severe, or unordered, gender, surgical location.
And then parametric versus non-parametric.
Second, we choose between parametric and non-parametric tests. Parametric tests, like the t-test or ANOVA, rely on calculating the mean and standard deviation, and they assume the data is normally distributed. It fits that classic bell curve. They're powerful, but sensitive to outliers.
And non-parametric.
Non-parametric tests, like the Wilcoxon or Mann-Whitney U, use medians and ranks, not means. They are robust to outliers and used when data is clearly not normally distributed or when sample sizes are small. For maximum power, researchers always prefer parametric tests when the assumptions are met.
So let's go through the decision tree. I'm comparing two groups, my new all-inside meniscal repair technique versus the traditional inside-out. Which tests apply?
If your outcome data, like the IKDC score, is continuous and normally distributed, you use a t-test. If you were comparing two independent groups, like the two different repair techniques on two different sets of patients, you use the independent samples t-test.
And if it's the same patient before and after?
If you're comparing the same person before and after surgery, or comparing two matched knees in the same patient, you must use a paired t-test. The paired t-test is more powerful because it accounts for the baseline individual variation.
And if that PRO data wasn't normally distributed, maybe because of a ceiling effect?
Then you shift to the non-parametric equivalents. The Wilcoxon sign rank test replaces the paired t-test for within-subject comparisons, and the Mann-Whitney U test replaces the independent samples t-test for comparing two unrelated groups.
What if I'm expanding my comparison? Now I have three groups: my new technique, the old technique, and a non-operative physical therapy group.
Then you must move to an analysis of variance, or ANOVA. This test compares the means of three or more independent groups simultaneously.
And if I'm tracking them over time?
If you are tracking the same patients at 3 time points pre-op, 6 months, and 1 year, you must use a repeated measures ANOVA, which is essential for longitudinal ortho follow-up as it controls for individual subject variability over time.
And this is where the advanced stats really prove their worth. Tell us about the ANCOVA.
The analysis of covariance, or ANCOVA, is a powerful variation of the ANOVA model. It's used when a researcher needs to statistically control for a potentially confounding variable. For example, if your 3 study groups ended up having significantly different mean ages at baseline, and age is known to influence WOMAP scores,
You'd use ANCOVA.
You'd use ANCOVA to statistically adjust the outcome means as if all groups had the same baseline age. This isolates the true effect of your treatment from the effect of age.
That's critical for research integrity. Now, if the ANOVA spits out a significant p-value, say p is less than or equal to 0.05, it only tells us that at least 2 of the 3 groups are different. We can't stop there, can we?
Absolutely not. You must perform post hoc tests, such as the Tukey or CDAC tests. These are secondary tests that determine which specific groups are different from each other. They prevent you from making a type-I error by adjusting the significance level for the multiple comparisons you're doing. The ANOVA is the warning light. The post-hoc test tells you where the fire is.
Finally, comparing categorical data, like comparing outcomes reported simply as excellent, good, fair, or poor between two treatments.
For categorical data, the gold standard is the chi-square test. It assesses whether an observed distribution of outcomes differs significantly from what you'd expect by chance. The Fisher-Exact test is the alternative used when sample sizes are very low.
And last point on describing relationships, correlation. How do we quantify how strongly a high preoperative IKDC score correlates with a high postoperative outcome?
If the data is continuous and normally distributed, you use the Pearson product moment correlation coefficient, or ER. This value ranges from -1 to +1. A value approaching +1 indicates a strong positive direct relationship. A value approaching -1 indicates a strong negative indirect relationship.
And how strong is strong?
For orthopedic research, the standard interpretation is crucial. A value less than 0.33 is considered weak. Between 0.33 and 0.66 is moderate, and anything above 0.66 is strong. If your data isn't normally distributed, the non-parametric equivalent is the Spearman-Rowe. This intensive review confirms that while our objective tools, our hands, our scopes, our imaging are fundamental, the quantification of patient perception through reliable, validated, and responsive instruments like the IKDC, WOMAC, and KOS is equally essential for defining surgical success.
Yeah.
True success lies in the meticulous combination of those objective findings and the rigorous statistical thresholds of MCID and MDC.
Okay, let's unpack this and leave you with the final clinical thought. We've established definitively that just achieving statistical significance, that tiny p-value, is never enough to justify a new procedure or treatment. We must ensure the outcome crosses the MCID threshold, the difference the patient actually feels, and the magnitude of change that justifies the intervention. When you are next reviewing a study claiming superiority for a new surgical technique, ask yourself, did they just achieve a statistical blip on a chart? Or did they actually change the patient's life by surpassing the minimal, clinically important difference?
That's the question.
And finally, we discussed the complexity of the Tegner activity rating, which can decline naturally as an athlete ages and shifts focus away from competitive sports. This raises a profound and challenging question for all of us involved in long-term orthopedic research. When assessing functional outcomes in former athletes 10, 15, or 20 years after an injury, how do we ethically and statistically separate the inevitable non-injury-related consequences of aging and lifestyle shift, the move from running marathons to running a business, from the true, lasting functional impact of the original orthopedic injury and our intervention? That separation is the next frontier of defining long-term surgical success.